Thank you for that presentation. We're going to start with questions and answers. For questions that have been submitted today, both online and in person, that the faculty have spent all of their lunch and most of the afternoon responding to. If you don't hear your question during this session, it will be answered and you will receive responses for every question that's been submitted. As you can imagine, we have some limitations with time, but we're going to cover as many as we can. Joining me up on the podium will be many of the faculty, including Alexis Kirk, Jennifer Frank, Francie Roskowski, and Deborah Dean Whitaker. The first question, I think it was actually asked multiple times, so of course we tried to bundle by themes. The first question, we are a small hospice, less than 20 return surveys for calendar year 16. Is there a threshold for public reporting? I recall reading or hearing that low survey return rate would not allow enough data for public reporting.
We do plan to have a floor beyond which your data will not be reported because it's not statistically sound to do so. We aren't sure exactly what that number is yet. You will be counted as having participated and be eligible to receive your full APU, even if you are not counted because you have too few responses. But you may not be publicly reported, and there probably will be a footnote saying why.
Next question. In answering J2030C, screening for shortness of breath, we are to consider whether shortness of breath is an active problem and the severity must be rated in any manner clinically appropriate. If a patient is admitted who is unresponsive and has an active respiratory treatment secondary to a respiratory disease process and during admission assessment does not have shortness of breath, and the severity of past shortness of breath cannot be determined by caregiver or medical record content, do we answer no, even though it is evident that shortness of breath is an active problem by the HIS manual definition?
So in this scenario, this is a patient who does have an active problem with shortness of breath. And so based on that, on the description, it sounds like it's well managed medically. So in this scenario, it really represents an example of a patient receiving treatment for an active problem, right, for shortness of breath. So you would answer the item based on that. Shortness of breath is an active problem for this patient.
Next question. I understand that if a patient dies before assessment of the beliefs/values HIS question, that the zero answer must be chosen. Is there any thought that an additional answer selection of death before assessment might be added? I'm asking because most of our nurses defer that question to our chaplains, who of course have 5 days to do their assessment.
So first, we just wanted to thank the provider here for their suggestion, and we wanted to clarify, again, the requirements of the measure here and what's also noted in the HIS manual, which is that any member of the interdisciplinary team or group can initiate that conversation. They can open the door. So you don't necessarily have to wait for a chaplain to do that.
Next question. New hospice received CCN February 2016. Submission rate to date is 67%, below the 70% expectation. Since a new hospice this year, will we be exempt?
So we wanted to first clarify that this answer is only pertaining to the HIS submission requirement. So for the purposes of the HIS, first let's point out that the CCN was received in February 2016. So when we're talking about data that you'll be submitting in 2016, that pertains to the fiscal year 2018 APU. So when we're thinking about whether or not that provider would be subject to the potential payment penalty for fiscal year 18, since in this instance the CCN was received before November 1st of 2016, that hospice is responsible for submitting the HIS data. If the hospice feels that there are extenuating circumstances that apply to their situation and end up preventing them from meeting the requirements for that particular reporting year, all hospices are always able to submit a reconsideration request.
Next question. Will non-hospice clerical visits from the community clergy count if they are documented in the chart? In many smaller counties, community clergy are very involved with families, and they do not need the hospice clergy.
So those visits items, O5010 and O5030, are intended to capture visits provided by the hospice. So unpaid visits conducted by hospice staff can be counted in O5010 and O5030, but visits that are provided by a community clergy member, like the patient's personal pastor, cannot be counted there.
Next question. When will the new discharge set results be publicized?
There's no date set yet for reporting the hospice visits when death is imminent measure of pair.
What percentage of HIS discharge submission, parenthetically April 1, 2017, is required to avoid APU reduction?
So the threshold for HIS records in calendar year 2017 is 80%. And we wanted to just note here that there's just one single threshold. So there's no threshold for discharge and a separate threshold for HIS admission records. That single timeliness compliance threshold consists of all of the records submitted.
When will hospice CAHPS results be publicly available?
As mentioned previously, right now, that would be summer of 2017. If there is a change, we will let you know.
Please explain the HIS submission guideline for a provider obtaining a CCN before November 1st. Should a licensed hospice collect HIS data for all patients served prior to obtaining the CCN and submit that data after the CCN is awarded?
So hospice providers are responsible for submitting HIS data for patient admissions occurring on or after the date that is noted in the letterhead of the CCN letter.
I get the next one. If the location changes between the admission and discharge, moving from care under one CCN to another, would the first location need to discharge the patient and the second location submit a new admission? The answer is yes. Next question. Applying for survey exemptions due to size. What if the size fluctuates throughout the year, but the majority of the time the census is less than 50?
Let me make it clear that the exemption for size is not about your average daily census. It is about the total number of unduplicated patients, caregivers, that were survey eligible and that you served in the prior year, which we also call the reference year. If you saw a total of fewer than 50 patients and caregivers who were survey eligible, then you can apply for the size exemption. This has nothing to do with your average daily census.
Who should be identified as the CAHPS survey recipient?
Okay, the primary caregiver as determined by the hospice should be the CAHPS survey recipient.
Please define primary caregiver. Should this be a person who is providing care or the patient's legal decision maker?
Okay, the primary caregiver is the person who the hospice has defined as the primary caregiver in the record. They don't need to be the patient's legal decision maker, and they don't have to be providing hands-on care. They just need to be the person that you as the hospice regards as the primary caregiver, or perhaps you could even call it your primary contact. But it is up to you to make this decision, but it is not necessarily the legal guardian, and it's not necessarily somebody who is providing hands-on care, because you see what could happen is you could have an aide then being considered the primary caregiver, and what we want to talk to is the family member or the friends of the patient.
Next question. We serve several patients living in assisted living homes. Are surveys sent to the primary caregiver who signed the caregiver consent form, parenthetically at assisted living, or to the family? And the answer is the same that was just given for the previous question. I'll also take the next. This question is about the primary caregiver. What if the patient is in a facility such as a nursing home and there is no significant caregiver? The patient signed EOB and no family members are involved. In this case, if you would, the facility is the actual caregiver. Would this be an excluded patient? And the answer is yes. Next question. The presenter mentioned that the threshold for the HIS is for timely submission. Does this mean that if the admission or discharged HIS is verified after the 14 or 7-day requirement, that is not a determining factor in the submission threshold requirement for the fiscal year considerations?
So the timeliness threshold criterion applies to the submission deadlines only, not those 14 and 7-day completion deadlines. So those completion deadlines are not a factor in APU determinations. The only thing that is a factor is compliance with the 30-day submission deadline.
Our agency is about 1 mile from the Canadian border. Family members do come down from Canada to take care of our hospice patients and are the PCP for them. They don't have American addresses. Are you going to change so agencies on borders can list Canadian or Mexican addresses?
I'm sorry to tell you, the answer is no. You must have an American address, and one of the reasons for this is simply that we would have to know too much about where the address is with respect to the border. So we just simply say you must have a U.S. address in order to be eligible to receive the CAHPS survey.
For clarification, on slide 8, you talked about marking all current pay sources. You stated if the patient had a Medicare Advantage plan that you would mark that. Would you also mark straight Medicare in this instance, since the Medicare Advantage plan would be waived and straight Medicare pays?
So item A1400 asks that you check all payer sources that apply. So in this scenario, both the response options for Medicare Advantage and for traditional Medicare would be checked.
With a patient who is unresponsive and is showing a mild form of pain, parenthetically grimacing, but becomes comfortable in appearance with body repositioning and comfort medications, for example, morphine, would you answer yes to active problem? And the response is yes. The next question is related to A0550, A1400, and J0905. The question is, are these effective April 1, 2017? And the response is yes. Next question for clarification. If a clinician answers yes to the new J0905, is the expectation that they will then complete the comprehensive pain assessment, but if they answer no, they will not be expected to complete the comprehensive pain assessment? And does this eliminate the previous pain security screening skip pattern?
So if the clinician answers one yes to J0905, which is the pain active problem item, you will continue on to J0910, the comprehensive pain assessment. If you answer 0 no to J0905, for the purposes of completing the HIS items, you should follow the skip patterns, which direct you to skip over the J0910 comprehensive pain assessment item. So the new skip pattern between J0905 and J0910 does replace the prior skip pattern that was in the original version of the HIS.
What is the time frame for the composite measure, monthly, quarterly, calendar year?
The composite measure will be added to public reporting in the future, and CMS will provide details via the hospice quality reporting website in the future about that.
You may have answered this, it looks familiar, but if a patient has a Medicare Advantage plan when they chose hospice benefit, it reverts back to the original Medicare. Would you choose box A, Medicare traditional fee for service only, or choose box A, Medicare traditional fee for service, and B, Medicare managed care Part C / Medicare Advantage? And the answer is both would be selected. If we have a comfort pack ordered with each admission, which includes morphine, does that mean that even if a patient denies pain, parenthetically no history or previous complaints, we are to complete a comprehensive pain assessment in HIS due to having morphine available?
So for this one, having morphine available in the comfort kit in and of itself does not indicate that pain is an active problem for the patient.
Next question from section J0910. Can you review how a pain AD tool would be answered here?
All right, so J0910 should be answered based on the signs and the symptoms observed by the clinician or reported by the patient or caregiver.
Will the presentation be sent out to viewers? I would like a copy. The response is the slides are currently available on the CMS Hospice QRP training page without answers. The presentations with answers and video recordings of the presentations will be posted following the training, and you will receive a notification when those resources are available. If the patient is currently hospitalized, what is the correct response for the hospitalization section?
So the fact that the patient is in the hospital does not indicate their preferences regarding hospitalization. So in this case, the hospice should still discuss patient preferences regarding hospitalization with the patient or the responsible party.
Next question, duration related to med half-life / breakthrough pain.
So we interpreted this question as someone asking whether the effectiveness of a patient's pain med, so if they're taking a medication that's supposed to be good for 4 to 6 hours, if they're having breakthrough pain before that 4 to 6 hour period is up, is that evidence of assessing duration for the purposes of the J0910 item? So the answer to that is assessment of pain duration is not equivalent to the duration of pain medication effect.
Thank you. Next question from the case study. Pain assessment items were less than 5 out of 7. Does this mean a fallout for comprehensive pain assessment?
So if there are less than 5 of the 7 characteristics that were assessed for pain, as was the situation in our case study today, then the patient does not meet the numerator criteria for the quality measure. But we got some additional questions about this in person that I'll use this opportunity to clarify. So we did want to clarify that even if you don't see 5 out of 7, you should still document what you do see in the record. So meaning if you only see that 2 things were assessed, so location and duration, then you just mark those 2 things for item J0910. And just realize that the specifications for the quality measure are a separate issue that will be calculated when we analyze the data for the measure.
Thank you again, Alexis. If you check the box to indicate pain is an active problem, but the pain level is currently 0, Do you then need to choose an assessment type and fill out what was included in the comprehensive pain assessment?
So if you mark pain as an active problem when filling out the HIS, yes, you do then move on to the comprehensive pain assessment item.
Next question. If a liaison saw a patient and asked them questions regarding their preferences for CPR or hospitalization in Section F, and 3 days later, the admission nurse asked those same questions, can we use the date of admission since she is filling out the HIS on admission and opening the discussion also?
So for this one, the first date of discussion that appears in the clinical record is the discussion that you should use to complete the items in Section F.
Or J0910. On the example, if the comprehensive assessment had been conducted on November 18th with screening completed on the 15th, would the hospice not get credit for the comprehensive assessment?
So to be included in the numerator for the comprehensive assessment quality measure, the comprehensive pain assessment must be completed within 1 day of the positive screen. So in the example in this question, that's correct. The hospice would not receive credit for the quality measure.
HIS case study number 1. When the patient stated preference was to not return to hospital, but would consider returning to hospital for symptom management or caregiver relief. It was said that he refused to discuss his preference. It appears to me that he did discuss his preference in light of earlier instruction that could be discussed even if undecided at the time of discussion. Am I looking at this correctly?
So we wanted to point out here that responding refused to discuss was the correct response for the polling question, which is separate from that case study question that we looked at. So in the polling question, the patient did refuse to discuss, and you may remember the documentation there was the patient said things like, oh, I'm just taking it 1 day at a time now, I'm just happy to be at home, whereas in the case scenario, the questioner is correct. The patient did actually list some specific situations in which he would want to go to the hospital. So in the case scenario, we did answer yes, and discussion occurred.
Next question. Will the composite score affect reimbursement or an overall rating at some point?
So right now, the HQRP and the public reporting is based on meeting the reporting requirements rather than performance on any of the quality measures.
Regarding the pain assessment, does a reference to how long the patient has been experiencing the pain, i.e. days, weeks, months, instead of how long does the pain episode last, that is, minutes, hours, qualify to report that duration was assessed? For example, as a reviewer, can I report that duration was assessed if there is a statement like, quote, patient has been experiencing this type of pain on and off for weeks, end quote?
So as noted in the HIS manual, duration captures how long a patient has experienced pain. This could include the time frame that the patient has experienced a particular episode of pain, so pain lasting hours or minutes, or pain they have experienced over a longer period of time, such as, well, my pain started when I had my surgery.
Next question, if J0905 is not included in the quality measures, will J0910 be included if it is only triggered by J0905?
So the current denominator inclusion criteria for NQF 1637, which is the comprehensive pain assessment measure, is tied to how you respond to J0900C pain severity. So for right now, responses to J0905 pain active problem do not impact the denominator for the 1637 measure.
When a patient elects the Medicare hospice benefit that had a Medicare Advantage plan prior to election, my understanding is that the patient converts to traditional Medicare. Why should we, in that case, select as payer sources both traditional Medicare and Medicare Advantage plan?
So the reasoning behind that is that item A1400 is collecting information on all payer sources available to the patient, regardless of whether or not that payer is paying for the patient's hospice care specifically.
Do you have training for clinicians in the field versus reviewers? If not, can you make recommendation of a good source?
So the training materials without answers from this training are currently posted on the CMS website, and recordings of the training and presentations with answers will be posted following the training.
And that appears to be the last question. There are others that were submitted that we didn't have time to work out the responses. Those will all be sent. Every question will be sent with a response after the training. Thank you so much for attending both in person and online. If you're in the room, please complete the evaluation. You may either leave it on the table and we'll come by and gather them, or you may leave it out at the table where you registered. We are now also going to have a meet and greet session with the faculty and the representatives from CMS. So if you'd like to put a face to a name or have an outstanding question that's burning, they'll welcome you at the back of the room. Thank you to all my colleagues, especially for the closed captioning. It's fun to watch. Safe travels.